Really appreciate everybody being here this morning, both on site here as well as offline or offsite. We have some online streaming going on, something we're going to move forward and continue to do in the future. And I think it provides a great opportunity for those that can't get here early in the morning and be with us. But we certainly appreciate the participation of everybody. We appreciate you guys being here. And quite honestly, we appreciate feedback. If you guys wouldn't mind giving us feedback, I think most of you, if not everyone, receives the right connection. On that right connection in the future, there'll be links to each one of these lectures, as well as kind of a brief summary, kind of a bullet point summary or a Cliff Notes version, if you will. So please don't hesitate to reach out to Melissa or to Kelly or to our outreach team with any suggestions or ideas for future topics or things that we could do better or improve on. Moving forward, we really are excited about this series and think it provides a lot of value. Today, I have the privilege to introduce Dr. Henry Ellis. Dr. Ellis is one of our orthopedic sports medicine surgeons. He is not only a phenomenal surgeon, but in general, just a great guy. He's a great mentor and a great leader, and we feel very privileged to have him here with us at Texas Scottish Rite. So without further ado, here's Dr. Ellis.
Great. Thanks, Jared, for the introduction. And I would just further remind everyone that we are actually, for the purposes of medical credits, we try to plan this a year in advance and have a relative curriculum. So lectures you guys want to see again, or topics that maybe we can help cover or find people to cover, or even maybe you guys help participate with some of that. We'd love to know any of that, and you guys just let us know, because within the next 60 days, we're probably going to come together and come up with a curriculum for the next year. So please don't hesitate to reach out. And from a digital media standpoint, we continue to want to improve our ways to access education that we provide. So allowing it to be live streamed or videoed afterwards has been really important and valuable. Not really certain how many people utilize this for their medical credits, but hoping to continue to move forward with establishing that too. And we hope to have every month. It seems to be that Brandy and our team have really make some tremendous progress. So we're really quite excited about that. And today we're going to focus a little bit on just the shoulder exam, the shoulder and elbow exam, and particularly focus on perhaps the pediatric arm of it. So I know most of us, or a lot of us in the room, because we've got a variety of crowd and as well as a crowd online, but we really want to focus our efforts on a little bit more how the pediatric exam may be different from the adult exam, and perhaps just go over some things. And if you guys have some helpful hints that you use in your practice, please don't hesitate to speak up or raise your hand. I just want to be sure that a microphone's in your hand so that everyone that's listening online can also hear from it as well. There's usually, oftentimes there's a couple ways to do the physical exam, but focusing on what you think the problem is, and even sometimes identifying whether it's an acute or traumatic injury will kind of lead you down the right path, and we'll talk a little bit more about that in just in just a couple minutes. I have nothing to disclose for this talk. The objectives here were really to talk about the history and physical exam for pediatric elbow as well as the shoulder. I'm going to try to do it in a case-based example, so it may not be as organized as history and physical and imaging, and I'm going to try to make it relatively organized, but just talk about some cases while we do it as well. And then I'm going to mention a few things about sports specialization, a few things that we've been working on here, a few things that I've been working on and trying to give you guys some information based on the latest research. So real quick on the shoulder and elbow exam, and I'll tell you, any exam I walk into, I really want to know, is this acute? Is this an injury-based problem? Or is it chronic? And so you can have a 17-year-old football player that heard a loud pop while he fell to the ground, or you can have a gymnast who has 6 months of shoulder pain. You can also have the same athletes, and you can almost reverse it when it comes to the elbow. The gymnast can fall on her elbow and hear a loud pop that was a traumatic injury that I would call acute. And then you have a quarterback that has 3 months of 3 months of elbow pain, and he also pitches at the same time he's a quarterback. So you can see how this can really not only change the way you ask a history, but it will change the way you have the physical exam. And the reason is oftentimes when you have those same two athletes, your differential is completely different. Traumatic injuries or acute injuries are very, very different from those chronic or overuse injuries. And maybe some of the counseling that you have will be completely different based on that knowledge of acute versus chronicity. And so for me, it's one of the most important things that I really want to hash out very quickly in my evaluation. Whenever you do an evaluation, depending on what you're evaluating, I'd strongly encourage not to forget about a good neurovascular exam. Whether you go by the root exams, C5, C6, C7, C8, T1, or whether you go by the nerves, it really depends on where you are coming from or what direction you're coming from, what you're thinking. Most of the times I'll go through my main brachial plexus nerves if I'm looking at an upper extremity exam, unless I think there's a neck problem, and then you may want to kind of think about it more in your C5, C6. We'll go over a little bit more of that in nature, but in a bit. But your neurovascular exam is a really important part of the exam. Whenever I'm doing a shoulder or an elbow exam, I always look at the neck, and I ask them to do a range of motion of the neck. And I oftentimes think a lot of our problems, particularly chronic pain, can be from hyperlaxity. So I include a hyperlaxity exam, or at least a screening exam, and we use the Baton score, and that's a part of my evaluation as well. If a fracture is suspected, you look at a patient, and they have a crooked arm, or they have a big bruise on their elbow, or they have a pretty large deformity, it's really easy for you to focus directly on that deformity without evaluating other structures around there. So just because you think you've already hit the diagnosis by looking at the deformity, we say in orthopedics, or we teach in orthopedics, to really look at the joint above and below aggressively. So if you have a forearm injury, we would look at both the wrist and the elbow at the same time, but I also encourage to look at the whole body to make sure, or at least the upper extremity, to make sure, at least from a screening standpoint, that you're not missing any additional injuries, because we do see that quite often. The first part of any exam is really, inspection. We don't talk about this a lot, but sometimes this can be the most valuable signs. And so for a shoulder exam, you've got to be able to look at the shoulder. So you've got to ask a male to take his shirt off, or you got to ask a female to put on a gown like a strapless dress, so that you get good visualizations of the clavicle, the acromion, and the shoulder blades in the back. And you can see on this one here, you can see that there is asymmetry on the right side, that you can look at a sternoclavicular injury. Now, oftentimes they may say, I have a clavicle fracture, and they point to their clavicle, but unless you look at it, you may miss the fact that this is a sternoclavicular injury, which is, in my opinion, a completely different workup. You got to talk about things like dysphagia and difficult breathing, and you'd consider a CT scan perhaps early on, as opposed to just basic x-rays. You can look at this exam here, and you can see that there's asymmetry amongst their pec major muscle, as the one on the right is a little bit more contracted and atrophic, indicating a rupture of the pec major. Looking at the elbow, the one on the left is a pretty normal looking elbow, but you can definitely see some clear deformities on the others, and these are quite obvious when you have your type 3 supracondylar elbow fracture, which to us may indicate more of an emergent or urgent evaluation. And then you may have a very small child, either in your clinic, in your urgent care, or that you're evaluating, and may have a small punctate bruise, but in a 6-month-old, this is not normal. This is usually indicative of a fracture, and oftentimes those kind of fractures can be non-accidental traumas. Looking at the shoulder exam as well can also give you some signs, whether it's acute or traumatic, but this external bruising could lead you towards that clavicle fracture versus other types of chronic pain that may indicate the need for an x-ray. Let's say if as you're a physical therapist taking care of a new acute injury, you may want to be more aggressive about getting x-rays early on. I usually start my evaluation from the back. I like to look at symmetry of the shoulder blades. I also, it is always interesting to me, as I never really realized when I was training how much I may see some atrophy of a muscle. We see it a lot in the quad after surgery, but oftentimes, without looking at the shoulder, you may miss some infraspinatus atrophy that can be from a spinal glenoid cyst that we know happens in volleyball players. Scapular weaving, this could be acute or chronic in nature. When I do my exam and I palpate, I always try to do it in a systematic fashion. And I always think that I do it the same way. And to me, this is the easiest way that I like to do it. So when I'm examining the shoulder, I start at the sternoclavicular, I start at the sternum, and then I move over to the sternoclavicular joint. And as I move down the clavicle, then you get to the acromioclavicular joint, which is number 3. The acromion is number 4. The coracoid is number 5. And then I move to the humerus, which is at 6, and then the biceps tendon, which is usually a little bit, you can feel your biceps tendon as you roll through the front part of your shoulder, and oftentimes that can elicit some tenderness as well. Now, a little difference between the adult and the pediatric is you will see some shoulder pain that happens in your gymnast or your thrower. And sometimes we forget that growth plate up here can be a cause of some significant shoulder pain as well. So palpating the proximal humerus about at the level of the growth plate sometimes can elicit a physical exam finding that can lead you to the diagnosis. The elbow is really the same thing, and I think oftentimes palpating the elbow can lead us to the diagnosis. Now, for chronic injuries in the elbow, our differential is a lot larger, and I still believe that physical exam can lead you to the diagnosis. So when you look at the medial side of the elbow, and you can feel it all on yourself if you like, but that medial epicondyle is really easily palpable. Now we see chronic inflammation of the growth plate. We call it medial epicondylitis on the inside part of the elbow at the medial epicondyle. Behind it, you can oftentimes feel that ulnar nerve. Just immediately behind that, you can feel the olecranon. Now, the olecranon has a growth plate, and it's not that uncommon to have a stress fracture of the growth plate, particularly in our pictures as well. So you can see how just that physical exam finding, those 3 areas of palpation can lead you to a significant diagnosis. On the outside of the elbow, you have very similar very consistent bony prominences. So the first thing I do when I examine the outside elbow, I'll show you this in just a bit, is I like to rotate, supinate, and pronate the arm so I can feel the radial head. I move immediately proximal to that, and you can feel your lateral epicondyle. In a flexed position, I then can feel the posterior aspect of my lateral epicondyle, and you can palpate the capitellum, which is a really poor area to palpate because that's where we see osteochondritis dissecans of the capitellum, a chronic injury that we see in our gymnasts and pitchers as well. You also have another opportunity on that lateral side to feel your olecranon, or the proximal aspect of your ulna, in that area. And so these slides are there for references if they would be helpful in the future, just when you're examining a kid or a child that has some of these that has complaints around the elbow. And don't forget that the elbow really has 5 growth plates, and so it's not really all that uncommon to see inflammation of a growth plate or a growth plate issue. Obviously, when you have a fracture involved here, oftentimes you'll see the deformity, but sometimes when you don't see the deformity, you can palpate these areas and you can have non-displaced fractures of those bony prominences as well. Range of motion, I think, is really valuable in the examination of both the elbow and the shoulder. And you can see I usually look at my range of motion from the back because I like to look at the way the shoulder blade moves. And we know that because every one of us sometimes has seen someone with shoulder pain and they have asymmetry of the way their shoulder blades function. And you can see that in this image here as an image of someone who has scapular dyskinesis. Their shoulder blade on her right side doesn't move the way that it should, or it moves asymmetric to the other side. And that's another indication of a problem that we may need to address, or identifying it. And it's another great example of, if you didn't take a look at this patient with their gown in a position where you can see their shoulder blades move, you may miss the diagnosis. Elbow range of motion is really the same, except oftentimes I encourage you guys not to forget about looking at supination and pronation. Sometimes injury to the radial head or to the radius can cause some asymmetry in supination and pronation as well. This is a little bit of my quick and dirty looking at the strength of the shoulder and the elbow, extending all the way to the hand. Particularly if you have an elbow fracture, a good neurologic exam of the hand is really important. We'll go over that a little bit more in detail when I have an example. Now, once you start thinking about what your diagnosis may or may not be, then I would refer to the things like the special exams, right? The ones that kind of lead you to the diagnosis. And so we use a lot of different types of exams to look for labral tears or shoulder instability or perhaps elbow instability or ulnar collateral ligament injuries. And we can use some of these tests. I'm not going to really go over those in detail today. I'll mention them briefly in just a bit. But the reality is for those of you guys that are on digital media or those that you go online, we have a lot of these videos that are online on how we like to do those in a variety of different ways in which we look at shoulder instability, how we evaluate for a slap tear, how we look for shoulder instability, whether it's a multi-directional instability or if it's acute traumatic instability. I'm just going to highlight Dr. Miller's exam here of a sulcus sign. Now, we see a lot of shoulder instability, and the reality is the atraumatic multi-directional instability is not usually a surgical option. It usually is an option that really needs physical therapy. Oftentimes these are volitional, and sometimes we see that there is a psychological component to it as well. So sometimes they work in coordination with our physical therapist. So I'm just going to play this video here, just so you guys get a good visualization of what a sulcus sign is. Now, I like to do this with them sitting up, just like Dr. Miller is, and I grab the lower aspect of their humerus as with his other hand as he's holding her shoulder on the other, so she doesn't collapse down. You kind of stabilize the shoulder as you do axial traction, and you can see how much laxity her glenohumeral capsule actually has. And you see how you see the outline of the acromion, and we call it a sulcus sign. As you produce axial translation, you can see how it kind of sucks in the skin a little bit, and it produces a little bit of a sulcus. Now, there's different grades of this, but the reality is most of us should not do this. And when we see it, we think that the capsule or perhaps some of the muscles around the shoulder joint are a little bit too loose and therefore may need a little bit more strengthening. And this is a classic example of someone who may have multidirectional shoulder instability and may need physical therapy to strengthen their shoulder. This is a great example of that. So I'm just going to go over a little bit of the live shoulder and elbow exam. So the first thing I'm going to do is obviously, we want to get a good look and do some inspection. And like I talked about earlier, I like to look from the front to start with, but primarily I think the back gives you a lot of information, and we don't want to forget that too. So I'll get you to pop your shirt off too. There you go. And so as they're just standing there, I want to look for symmetry, both at their elbow and at their shoulder areas, their pec, their clavicle, acromion, sternoclavicular joint. I'm going to ask you to turn around for me. And then you get a good look at their back too. When you're at the back, you got a great opportunity to look at their cervical spine as well as their spine. Go ahead and touch your toes. In the adolescent age group, okay, perfect. Now go ahead and stand up for me. In the adolescent age group, I always ask them to touch their toes. I want to screen for scoliosis. Sometimes we'll pick it up on our exam, and you'll see some asymmetry in the rib humps that many of you guys are used to doing already routinely. And don't forget about a cervical spine exam. I usually ask them to put their chin to their chest, their head back, side to side, and their ear to each shoulder. But what I really like about the cervical spine exams, I want them to do it against resistance. Go ahead and put your head back towards my hand. There you go, real strong. Does that hurt? Okay, now forward for me. Does that hurt? Now, if that reproduces any pain in the neck, you can do a more detailed cervical spine exam, or any radiating pain. You may want to focus your efforts back on that cervical spine exam. Okay, I'm going to ask you to put your arms and reach above your head from the side, going all the way up. Go ahead. Great, and come down. Great, we're looking for symmetry of the shoulder blades as they go all the way up, and you're also noting their range of motion as they reach terminal abduction. Do the same thing, but go forward for me. Great, same thing here, looking for symmetry of their shoulder blades as well as range of motion. Okay, we'll start your right arm and climb up your back as high as you can. Great. This is a test I use for internal rotation. I document where on their spine he's able to achieve internal rotation, and I typically would then classify according to the level of the spine. I would give this a T12 internal rotation, up to T5, sometimes L5, or even your
I then do a palpation exam at this point. And so I'm going to palpate those same palpation marks that we showed you on that presentation. Those are there for reference. So I start here at the sternoclavicular joint, and I'll do this with both hands, and I'll go routinely through each side. But we'll start at the sternum, the sternoclavicular joint. I move over here to the clavicle as I climb all the way over here to that small divot that you see here over the acromioclavicular joint. And then I go to the acromion here. You also have growth plates over the acromion as well. And so in adults, we may see osteochondritis as an unfused growth plates, but sometimes you can see that as an overuse injury in a kid as well. I move over here to the coracoid, and then I feel the proximal humerus. And then as I internally and externally rotate the head of the humerus, we've all felt that biceps tendon as well. I like to finish my range of motion exam at this point after I've palpated. So I'm going to put your arms to the side here like this. Open up like a book. I look at his terminal external rotation, which is about 80 degrees here. Move your arms up, and this straighten them all the way out, palms up to the ceiling. I like to do this in a consistent fashion with palms to the ceiling. I'm looking now at the elbow range of motion. He's about 0 there, thumbs to the shoulders at that point, and that's his terminal flexion of his elbow, about 145 there. Put your arms to the side here, rotate out like that. So we have supination about 90 degrees, pronation there. There you go. And pronation in 90 degrees. So that's a little bit of a physical exam of both the shoulder and the elbow. Now I'm going to take a look at his strength, and I'm going to go over some of the findings as I talk out loud. Put your shoulders up just like that. Yep. So looking at his deltoid, also axillary nerve, also C5 nerve root. Go ahead and thumbs down here. Resist me going up here. So that's a test for your supraspinatus, or one of your rotator cuffs that's primarily injured, is to put the thumbs down. You rotate the arms in about 45 degrees, and he resists upward pressure. Rotate the arms in here, push up. That's resisting forward flexion. Also looks at the function of your biceps tendon. I'm going to bend your arm here. Resist rotating your arm out. I like to look at resisted supination. Rotate it. There you go. Resisted supination, sometimes I can reproduce pain up at the biceps tendon as well. Flex your arm for me. Resisted elbow flexion and elbow extension, looking at both your brachialis and your triceps. So a really quick and easy way to look at your median nerve, your radial nerve, your anterior interosseous nerve, your posterior interosseous nerve, your ulnar nerve, is just to ask them to put their thumbs up, bend their thumbs down. That's looking at the PIN, and the AIN is to watch that IP joint flex and extend, which is a component of both your radial and your median nerve. And I ask them to extend their fingers all the way out real strong, and you check their interosseous of their nerves for their ulnar nerve. You check those, and you can pretty much, that's a really easy way to confirm those major nerves are intact. Now, I'm going to focus a little bit more, and then once I kind of go through that quick exam, I can move a little bit closer. Now, once I grab his hand, I can feel for that radial pulse, move over and check capillary refill if I need to. I can examine the wrist briefly if I need to as well, and I can do a sensory exam. And I may go through it the same way in which I do a systematic fashion. I'm going to check that C5 sensory over the lateral aspect of the deltoid. I like to look at the medial and lateral side of the forearm. When you examine sensation of the hand, I typically ask them to kind of make a gun motion, so I can look at both the radial sensation on the outside and the median nerve sensation on the inside. And then as they relax their hand, I can get the ulnar nerve, which is on both sides in that hypothenar area, or in their palm closer to their small digits. And then you've done a very quick exam of their sensation as well. Obviously, any positive findings would lead you to want to do a little bit more of a detailed exam, really intended to be a quick screening exam as well. When I get up close to the patient, then I like to look a little bit more seriously at the elbow, and this is where I can go through the elbow exam like we talked about. Now, the first thing I always like to do is feel that radial head, and I put my thumb right on that radial head as I supinate and pronate, and this allows me to really get a good idea of exactly where that radial head is, because I can feel the prominences as I rotate. As I go slightly more proximal, you feel the next bony prominence, and that's your lateral epicondyle. As he flexes his arm up, I can follow that lateral epicondyle to that posterior prominence, and that's your capitellum. And that's where we're going to see osteochondritis dissecans, like I mentioned before, in your pitchers and your gymnasts. It's a great opportunity just just to continue to your next bony prominence, which is your olecranon, and we'll see problems both at the growth plate as well as stress fractures there. As I move the arm, as I externally rotate the arm, you got the medial side of the elbow, and you can see here, common injury we see in pitchers and throwers. I palpate the medial epicondyle here. If this is tender, I then may go a little bit more proximal or a little bit more distal to have a much better idea on exactly where this is tender. Sometimes we'll see some soft tissue tenderness. Also, I'm going to make a fist. Flex your wrist for me. And this will fire this muscle group through here, reproducing some of the pain. And that's what we call little league's elbow, or little leaguer's elbow, where they have inflammation of the medial epicondyle here. As we go slightly more posterior here, you see the next prominence is the ulnar nerve. Oftentimes we can see some ulnar neuritis. And then as you go a little bit more posteriorly, you hit that olecranon again from this side. So really going from front to back on both sides. And that's where we'll palpate. When you have, one of the exams that we do to not only reproduce some of the pain or to try to look at some of the structures around the elbow is what we call the milking exam. And the milking exam is really forced external rotation to stretch these inside structures through here. So I'll hold my arm at the elbow and I pull on the thumb almost like I'm milking through the thumb. And this may reproduce some pain in here, indicating some overuse injuries of either the ulnar collateral ligament or the medial epicondyle. Now, the milking exam can then be taken a step forward, and I'll even rotate. We call the dynamic milking exam, where I'll flex and extend as I'm grabbing the thumb, externally rotating, trying to reproduce stress through here, kind of like a pitcher will do when he throws. And that's called the dynamic milking exam. All right, Andrew, I'm going to get you to lie down for me. I'm going to have to put your head over here if you could. Right there. Now, one of the common things that we see, come this way just a little bit, is instability. And the one test for instability, if you're wondering if it was a shoulder dislocation or a labral tear, is really the apprehension relocation sign. And so as you rest their shoulder blade on the table, I'll externally rotate their arm. Andrew's got about 90 degrees here, and I'll try to continue to externally rotate it under stress. And he'll either tell me that it's in pain, or he'll jump up and say, I think it's about to come out. And so you know that that's apprehension. He gives the apprehension sign that a shoulder may pop out. And then the relocation sign is I'll push posterior translation on the humeral head, and I'll say, well, does that make it feel better? And I'll say, oh yeah, it feels a lot better. So that would be a positive apprehension relocation sign. Really a sign that he has some instability or some potential for instability. Okay, go ahead and sit up for me. I'll get you to put that down. Can we give a round of applause for Andrew real quick? I really appreciate it, thank you. We, as you do an exam, you can always take it a step further if you're looking for a labral tear or you're looking for biceps tendon problems, or really try to narrow your exam. And then that's where you really can get into this long list of special tests. So as a screening exam, that was my intention, is to try to present a screening exam. But I would also tell you that as you start getting closer and closer to the diagnosis, I really believe that a majority of my diagnosis can really be made with palpation alone and looking at range of motion. But then as you are trying to look at those other issues, whether it's shoulder instability or a labral tear or ligament problems, then you can kind of go through some of those other tests. And I would tell you that online we have available tests or links that are available to special test exams if you want to take that a step further within your all's practice. You guys have any questions or any comments about that? Anything that you guys do on your screening exams that you would like to mention or talk about? Okay, well then I'll move forward. And now what I'm going to really talk about is a throwing injury to the shoulder. I'm going to use a case example, and we're going to kind of go through it together. And really primarily looking at overuse injuries of the shoulder. And so we're going to start with Dave. And Dave's a 13-year-old male, and he's been having shoulder pain while pitching for about 6 weeks. And Dad says my rotator cuff, or my son's rotator cuff, is a little inflamed. So let's just, you're just now meeting the patient. I'm going to ask for hands in the room. For those of you guys that are watching online, you can raise your hand if you want to as well. But when you start your history, who's going to really dive in to the pain versus diving in talking more about his sports participation? So I'm going to ask for a raise of hands to talk about the pain first. Okay, for those of you online, not one person raise their hand. Who's going to talk about their sports and their sporting activity? Okay, well, we got the majority of the room talking about their sports and their sports activity. And the reality is we're going to end up talking about both, right? But when you are presented with this picture, you're primarily going to start wanting to know about how aggressive this kid is. You know, how intense is dad if dad's like, you just got a rotator cuff that's inflamed. So this is Dave here. And again, we're going to talk a little bit about the acute or chronicity. Did the pain start kind of gradually as he started pitching, or did we find that, you know, it was all of a sudden during a pitch, you heard a pop and it hurt? Now that may change your exam slightly. Talk a little bit about time management. You know, how much sports are you doing, and is it always activity-related pain? Does it hurt in the morning? Does it hurt while you pitch, or does it hurt an hour after you pitch? How much is that influencing what you're doing? And this can be really important, particularly with this picture here. Any popping or locking symptoms, that can also be valuable. And then we've already touched on the exam. We have a reference guide that we use, and we often use this in our talks to refer to say, hey, this is a little bit of the common injuries in pediatrics. And I'll tell you that for those of you who primarily take care of adults, the differential is very different than in kids. So you may have bursitis or tendonitis as an adult thrower, or even a mature thrower, a collegiate level thrower, but you're not going to oftentimes have that in a kid. In fact, oftentimes we find that that's not really very high up on our differential at all, is to have tendonitis. We just don't see it in kids very often. Their areas of inflammation and irritation are very, very different. And so this is a list of the common injuries or overuse injuries that we see. And when it comes to imaging, you'll really see that the imaging is really all the same. We really want 3 views of the shoulder. The Grashy view, the AP Grashy view, it's just an AP of the shoulder. It's just a special technique, but your radiology techs will know all about that. And then you really need a lateral-based view. An axillary or a scapulae, we usually want both of them. Sometimes their shoulder hurts real bad and they can't give you both, but we have to at least have one. I'm going to tell you why. Because this image here is an anterior posterior of a shoulder, okay? It's an AP of a shoulder. You can see the head of the humerus. You can see the head of the humerus here. Let's see. The head of the humerus here with the glenoid, and it looks like it's pretty well reduced. You see a little bit of a bone fragment down here, but sometimes you can have a completely normal looking AP, but yet just because of the angle in which it is taken, sometimes this can be a posterior shoulder dislocation. And so you've got to be able to have those 2 views, or you may find yourself missing a shoulder dislocation. Now, going back to Dave, you know, he really didn't have an injury or an event. He's got some lateral shoulder soreness. It's activity related. It doesn't hurt unless he pitches. He's an all-star pitcher. He plays in 3 leagues. He's really played for the last 12 months. He can't really remember the last time he took a break. And, oh, by the way, I don't need a pitching coach because my dad is my pitching coach. You can see where this is going, can't you? So he clearly has an overuse injury. Humeral epiphyseal lysis is what we use as a term as little league shoulder. It is very common, particularly in these areas of growth, particularly in these young kids that are pitching quite a bit. But the other differential could be some instability or scapular dyskinesis, or sometimes we'll see internal impingement, which may be applicable in both the adult and the pediatric population. Now, what is this? Well, it's an injury to the growth plate. It's really a stress fracture to the growth plate. The growth plate is soft cartilage. And so as you pitch and you rotate, the body is looking for the weakest link. And because the growth plate is so soft, that growth plate will start to split a little bit or widen. And then sometimes it just doesn't work quite as effectively. So we think it's a very serious injury. Now you can see the x-ray here. Similar x-ray that I showed before, except you can see where that arrow is a little bit of a widening of the growth plate. Now, these symptoms is usually kind of the chronic, long-term pain, not one-time event. Usually it's a kid, when they transition from little league pitching to a little bit more serious pitching, oftentimes their pitch form is not great. And so there's certainly pitch forms that occur in the little leaguers, and then as they get a little bit older and they produce more velocity, they can't pitch the same way, or they are going to injure their growth plates at the shoulder and at the elbow. And so you can see here, but let's just say that you've got an x-ray, you're looking at an x-ray, and your radiologist says possible widening. Don't hesitate to get contralateral imaging, because you can see here how a side-to-side difference can really tell you the difference when you're looking at the growth plate if you compare the location of the arrow from one shoulder to the next. Really, this is rest. It's rest, rest, rest. You got to quit pitching. You got to quit throwing. And oftentimes Dad will say, well, can he still bat? Well, maybe. Well, how about first baseman? He doesn't throw a lot. He's still a real good first baseman. He can play. So you really got to emphasize rest. Now, once you get past that conversation, and it really is an important conversation for you to have with the parents and be an advocate for the coach, there is some things that are really important, because we do think that poor form has a lot to do with this. So I oftentimes will advocate not only a pitch throwing program, but a pitching coach that is not Dad. Oftentimes, physical therapy is really valuable because they have poor scapular control, and they have poor scapulothoracic musculature as well as rotator cuff. So if the patient's not evaluated by a sports medicine doctor, and perhaps in your pediatric clinic, and you don't have a lot of resources, this is a really valuable time to talk to a physical therapist and to have them work with them, because I do think it will decrease injuries later on. And then education is really important. Now, I don't really think that this is a problem with his anatomy. I think it's a problem with our culture. We know that most middle schoolers that are involved in competitive sports, or a lot of them, will have overuse injuries. And really, it's becoming a big deal, because I think many of us in this room, well, actually, I'm getting older and older, so it's not many of us in this room, but some of us in this room, some of you guys may remember this culture, but we really went from the picture above, which is one of my favorite movies, The Sandlots, to a picture below, which is what my kids are currently doing at a very, very young age. And so, we've really gotten into less free play, more competitive sports, single sport play, lots of organized sports, and it's becoming quite a bit of a problem. The statistic that I really took from a talk that I saw at one of our sports medicine conferences really talked about how in the year of 2000, the average little leaguer took 3.4 months off a year from pitching, and in 2011, an average little leaguer takes 1 week off per year, and that is usually between Christmas and New Year's. And nowadays, when you talk to your high-end little league pitchers, you'll ask them, how much time have you had off in the little year? And when mom and dad are trying to think and they're looking at their phones about the break they had between two tournaments, oftentimes that doesn't count. But it is really a change in our culture. I was fortunate enough to participate with one of our national committees in which we look at safe sports, and we put together. We as a committee, we went through and we tried to pick out what we thought were the best articles for parents of youth athletes to start reading. And so we've created some digital media, and I'm going to play this here as one of the articles that has to do with throwing injuries. Another article looks at the risk factors of adolescent pitchers for shoulder and elbow injuries, and they found 5 risk factors: age, height, and pitch velocity, but more importantly, are modifiable factors that we can influence our adolescent players in, including playing with arm fatigue, as well as playing for multiple teams in the same season. These authors also endorse Major League Baseball and USA Pitch Smart guidelines. So that article, the Pediatric Orthopedic Society of North America, Positive Coaching Alliance, as well as Scottish Rite, kind of collaborated to kind of come up with really important messages. And when I read this article, I was really compelled, because it took all of the medical articles and it came up with the recommendations. And those were really the recommendations from a collection of all of the articles. And that's what really was in that systematic review. Now, there are a lot of resources for parents, for those of us in the room. I oftentimes will defer to families and say, go read about these online, because, oftentimes the education is vast, and the more we can talk to the parents, the more they will influence our coaches. So I strongly encourage them to go online and look up and read about it, so that they know some areas that we would advocate and we would endorse in order to help kind of teach their kids what smart sports is really all about. Now, I don't really think this is necessarily the parents' fault or the kids' faults. I really blame Malcolm Gladwell for all of this. And I don't know if you guys have read this book, but the 10,000 hour rule means you can't be really good at something unless you practice for 10,000 hours. It was actually the original published article that he was quoting in his book that he popularized was all about violinists, right? So violinists have to practice for 10,000 hours to be really, really good. And so I really blame him for this. But I would also tell you that the article he quotes that he popularized for the 10,000 hour rule also forgot to mention what was a very close second place to really being good at what you do and being an expert at it. Does anyone know what that is? Well, it's sleep. So you got to have good sleep in order to be really good at what you do. Well, he doesn't mention that. He just mentions you have to practice for 10,000 hours. So I really love his books, but I put him to blame for some of the stuff in our culture right now. A good friend of mine from UCLA, Jen Beck, very, very bright, new and up-and-coming surgeon. She actually represented an article talking about sports specialization. I'm going to play her short segment from the same collection as well.
This study was a survey of over 2,000 athletes looking at sports specialization and those risk factors. What they found is that the previous guidelines really hold true, that athletes should not participate in more hours per week of organized activities than their age, with a maximum of 16 hours per week. They should not participate in more than one organized sport at one time, and they should take some time off and not participate in more than 8 months of organized sports.
Those video clips, the entire clip's about 5.5 minutes. We then broke it up into 10 short segments if you're interested in certain body areas and body locations. And we will send out a link to all of those videos. They're also on the Positive Coaching Alliance as well as the POSNA Ortho Kids website if you want to refer to some of those articles as well. And I'll tell you that, it is such a challenge. And when I put together, I was the chair of the committee that put this together, and when we put together this article and I was reviewing it, my wife heard that from the other room and said, well, that's not going to happen here. When she heard about the sports specialization, she says, well, our kids play 4 sports at the same time, and we do this year round in this household. That's always not an easy conversation. If I can't have it with my wife, it's going to be hard to convince parents to have it too. Just to talk about the shoulder, physical exam, don't forget to stick with the basics. We do have growth plates, and I do believe that your basic shoulder exam without the special tests can oftentimes lead you to the diagnosis. If you're a healthcare provider ordering x-rays, don't forget about that lateral. We usually like the axillary and the scapular Y. Rest, but also education can be really important in some of our strategies to really improve some of these injuries. And now I'm going to switch gears, and again, I would open it up for any questions or any comments about shoulder injuries at this time, if anyone has any. Perfect. I'm just going to wait for a microphone, and Jared's coming with yours, Jeff.
I was just going to ask, or maybe you can expand on a little bit about the rest, like what you normally will tell your parents or your kids for these either growth plate injuries or maybe even somebody that's just on maybe going down that bad path and you want to give them something from an injury prevention standpoint. Like, what are you going to tell these kids? Because they're going to ask how much time versus just you need rest. What will you typically tell them coming out of an injury, or like I said again, just in a prevention standpoint?
Yeah, so I'd put a pretty hard stop on 3 months. I think these kids don't have enough rest, and frankly, they don't know what to do with themselves when they do have rest. And so I put a hard stop at 3 months, and it always makes me feel better if they are willing to see a therapist, because I feel like I can work with them to continue to hammer in the education piece and to continue to work through what the plan is going to be. Now, it's a hard stop at 3-month rest. However, you can't have a hard stop and then a hard start. And so there's a transition period that you have to also discuss with them about. And so a throwing program would start at a 6 to 8 week program if you're going to return to throwing, and as well as a high level pitching. And so that transition is usually going to start not right at that 3-month mark, but you may want to start that transition somewhere between 8 to 10 weeks if they're completely asymptomatic. But I would only allow that if they were working with a therapist or someone that can help them in a transition program at that same time. But I at least want 3 months of rest from their team. Go, Laura in the back.
Hey, shout out Daniel Stokes for this question. He wants to know how often you look at thoracic rotation in your throwers.
How often I look at thoracic rotation?
Yes.
Probably not enough. I think there's some limited, I think that there is a lot of back that has to go into their throwers, and I think that's where some of our basics in our exam are, that we'll do a little bit of a screening, but when you start thinking about that overuse phenomenon, you can be more detailed in your exam. So if you feel like there's an overuse in your young throwers, I really think you have to take it a step further and look at their rotation around their shoulder. Oftentimes we look at things, we use this term glenohumeral internal rotation deficiency, where their throwing arm has less internal rotation. So if you're looking at their rotation, you'll know that their non-dominant arm has a lot of internal rotation while their other one doesn't, but it doesn't just stop at the shoulder. You've got to also look at their back, and sometimes their lower extremity and their hip and their pelvis can affect a lot, because if you think of a pitch involves the entire body. And so you really have to do a head to toe, and that's where you've got to take your exam to a much, you got to kind of expand your exam much further and not just start with your shoulder, because you'll find some stiffness. And in those overuse injuries, once you've diagnosed it, you really need to start looking at other areas to cause it, because that's where you really want to look at their thoracic rotation, as well as some rotation around the shoulder. And even elbow injuries, people don't think about problems with their shoulder, right? In a thrower, if your shoulder's not working well, you're going to transmit all of your force through your shoulder. Through your elbow. And that's where you're going to end up having all of your overuse injuries on the inside of your elbow. And so you really got to start looking at the entire body, the wrist, the shoulder, the back, once you start establishing that there is a problem there.
Going back to the rest, when you select the 3-month rest and it's a baseball player, will you still consider a rest if they do another sport like track or bicycling? Is that still considered a rest?
Yeah, that's a great question. Yes, I do consider it rest. I do think that a lot of I don't want to advocate inactivity, but I do think a rest from that particular sport is really important. So, can you rest from baseball but still be your high school quarterback? Probably not. But if you take a 3-month break from baseball and you want to do cross country or track or something else to remain active, I oftentimes find that is really valuable too. And a lot of our kids, they want to be active and they want to be athletes. They don't want to not be inactive. So I would advocate for that. But I think it's an also good, healthy time to remind parents that we don't always need organized sports for our children as well. So there's really 2 messages there that you've got to be sure to balance out when you counsel the families. Great questions. Any other questions? Okay. We're going again, I'm going to talk about elbow injuries. Now we're going to switch gears a little bit and really talk about osteochondritis dissecans of the elbow, which to me is one of the more important, challenging areas to treat. And this is where I use all of our overuse injuries, and I say that this is really what I believe is the end game. This is what we don't want to happen, is to get to a condition called osteochondritis dissecans. So I'm going to introduce that to you guys in just a bit. We're going to start with Lexi, who I know very well, 11-year-old female. She's a level 9 gymnast. She's had several months of elbow pain, and it continues to drive her, but she just kind of pushes through it because she's really a resilient athlete. If you knew Lexi, you knew what I was talking about. The great thing about the exam of the elbow is I do think, just like the shoulder, stick with the basics. If you palpate, you'll oftentimes figure out what the problem is. But I oftentimes have to explain to the families what's going on. Now, this is really, this picture is one of my favorite pictures. It's an old picture, but it talks about what happens during a throw. Now, when you throw a ball, you produce a lot of velocity. Now, what you do is you have tensile forces on the inside of your elbow, and you have compressive forces on the outside of your elbow, all right? And so gymnasts have kind of the same problems. Now, it's different because they tumble with their hands overhead, but we see a lot of the same injury patterns between the two. So I think that a lot of these same rules exist for both of those. Now, when you have that medial stretch or that tensile load, that oftentimes will produce, if it's a repetitive load, to medial epicondylitis, which is inflammation of the growth plate right at that inside mark here. Boy, you touch it and you know that you've hit the diagnosis. It's just like Osteochondritis. At least that's how I view it. Now, looking at the other side of the elbow, you can get, as you flex the elbow, you can push on that lateral prominence on the outside of your elbow, and that's oftentimes where we see that capitellar osteochondritis dissecans. Now, on the back of the elbow, sometimes we'll see a little osteophyte or a bone spur, or we can see a stress fracture by palpating the back part of the olecranon as well. Just like the shoulder, we've got these handouts that are available in PDF format. They're also available online. But the good news is it helps you kind of hone down what we do. Well, in an elbow, I think it's really simple. We usually give two views, an AP and a lateral of the elbow. The differential to an elbow is bigger than it is to the shoulder. Is that because we don't know as much about the shoulder? Maybe. But there's just a lot more that's going around the elbow. So this is a long list. I'm just going to touch on a few of the more common ones. Medial epicondylitis, you've heard me talk about this. It's a repetitive throwing or tumbler. You can see on the x-ray there that it got just a little bit of changes over that medial epicondyle there. Sometimes getting contralateral images will help with the diagnosis too. This is a very similar message to the Little League shoulder, which is rest, 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 and education. If there's a microphone to give Dr. Miller, I think he has a question.
Thank you. I was just going to comment that I often refer to it as medial epicondyle apophysitis as opposed to medial epicondylitis, just highlighting the fact that this is a skeletally immature patient, and it's actually often an injury of the apophysis that we're dealing with. It's a little bit different than sort of the adult version, and a lot of parents will come in and refer to it as golfer's elbow.
That's right. Yep. And golfer's elbow is usually the soft tissue, is oftentimes the soft tissue that attach, the muscle group that attaches to the medial epicondyle. But yeah, technically speaking, it is an apophysitis of the medial epicondyle, and the nomenclature is different. And I really like that, Dr. Miller. I appreciate you pointing that out. An olecranon stress fracture, we do see quite a bit. Sometimes this may take 9 to 12 months to heal. Sometimes it does require surgery for it. You can see this kid from South Texas healed his quite well. Sometimes we see some soft tissue over the back part of the elbow. X-rays and MRI are completely negative, yet they have a physical exam consistent with osteochondritis dissecans of the capitellum, and sometimes just by palpation alone, you can identify that. And we're going to go straight to Lexi, who has had, as I said, several months of pain, limited range of motion. She can only extend to 10 degrees, which means one arm is all the way straight, one lacks about 10 degrees. And she's tender palpation directly over her lateral elbow. And you can see her lateral, her images here, and you can see that she's got some irregularity over the lateral, over her capitellum that you can see here, where there's just that irregularity, or you see that sliver of bone here, where it really is a delay in the ossification, or it's an irregularity of the ossification there. We know that this almost always happens in pitchers and gymnasts, and it is lateral elbow pain. And I really find that sometimes it's really difficult to get the diagnosis. Sometimes it needs an MRI, and most of the times for treatment purposes we get an MRI. But I find that families have no clue what I'm talking about. And so when you look at an elbow here, that's the area of concern. You can see how it just looks a little bit darker on x-ray. Now, the reason why we see osteochondritis dissecans is because there's a lot of blood vessels that feed the bone there. Now, what happens is you put a little bit of stress on this, and a little bit more stress, and a little bit more stress, and then what you find is that stress, then as you throw and as you're a gymnast, it just continues to occur, and it repeats, and it repeats, and it repeats, and it repeats, until that blood vessels decide that I just don't want to work as hard. And I'm done providing blood flow to this area. And then what happens is you get an area where you lose blood flow and the bone becomes necrotic. You have dead bone there. And that's really what osteochondritis dissecans is you have a normal blood supply, you lose it, then you get normal necrotic bone or dead bone there, and now we have to figure out, how to fix it. The body there's two pathways. The body can heal it on its own without stress, or you got to surgically fix it. And that's what we see with osteochondritis dissecans. We use MRIs almost routinely on all of these. And our treatment, sometimes we can treat this non-operatively, and more commonly in the knee, we can treat it non-operatively, but in the elbow, it's really hard. And some of our original studies, you can see there's a very, as you can see here, some of our non-operative studies are very, very old, and they don't do very well, particularly with athletes. And so then we start talking about, well, when and how do we operate on these? And the reality is we used to take them out and just say, I'm going to remove this piece and go back to throwing and tumbling, and you'll be fine. And we found out that doesn't work very well. Now, sometimes we can take them out and we can try to stimulate more cartilage, and sometimes that works. Sometimes we can go in there and fix them with some screws that you can see here, and this actually healed quite well. This is a gymnast of mine. And we know that the younger patients, the smaller lesions, work really good with fixing them, but fixing them is not for everybody. Sometimes this is what it looks like in an open surgery. You can see right in through here, you have normal cartilage. This, it looks like a pothole in the cartilage. There's no cartilage. The bone underneath it is dead. And this is sometimes what we're looking at. And sometimes we got to replace it with a cartilage transplant. And you can see that's the same patient here, in which you can see we put a plug that is a cadaver, and it's a fresh cartilage and bone there. There's a lot of different ways to do this, but it turns out that these actually do pretty good when we replace it and transplant it. We usually think it's the last resort, but the reality is when you look at another systematic review of meta-analysis, you can see that most of them that undergo this cartilage transplant, they end up doing better than anyone else. And so sometimes that's what we like to do. So back with Lexi, we put a camera inside of her elbow joint. We saw this loose body that you can see on the top. We took it out. You can see it's just over a centimeter. Here is the images. I'm sorry for the gory images, but these are the pictures here where you can see we did a cartilage transplant type of procedure. We put a net of cartilage cells right on top of it, and then you can see where Lexi is now about a year later. She's back to where she wants to be, and her x-rays look like they've healed in with some bone irregularity, but overall look really good, as well as her MRI. So just talking about the elbow a little bit, again, I can't hammer enough about the physical examiner is really the key to the diagnosis, and then that can kind of lead us to the treatment. I do think that the elbow, you almost have to look at this differential list because it's much greater than the shoulder. The AP and the lateral of the elbow is the key to the x-rays. Just like the shoulder, it's rest and education, and that's really the value of what we need to educate our families, particularly when we see overuse injuries. So that's all I've got. So I think we have about 4 minutes for questions.
We're coming up on having direct access for a limited amount of time, probably 10 or 15 days. So we're going to be kind of forced to evaluate these things. Do you have some resources similar to like Ottawa fracture rules for the ankle, for the upper extremity that would be helpful tips for us to know, like, okay, we need to make sure we refer this out, make sure we don't miss fractures, because we don't have x-rays obviously in our facilities. So it's sometimes helpful to have the specific guidelines that lead to when you know that you have these 4 things, then the likelihood of them having a fracture is very high. Is there something like that for the upper extremity or?
Yeah, Gray, that's a great question. And I'm not familiar with anything in the upper extremity that has really been as well studied that we can use as the Ottawa ankle rules, which for those of you, many of you guys know what that is, but that's the Ottawa ankle rules really dictate there's 5 locations around the foot that if you're tender on those bony prominences, it's more likely to be a fracture, so you're more likely to want to get an x-ray as opposed to many soft tissue injuries like ankle sprains that we rule out. Grady, honestly, we don't have that that I'm aware of in the elbow, but I would tell you that in the elbow, the acuity is in the patients that I see, if I had to give you guys any rules of thumb, I would say the acuity of the injury is what's valuable. A pitcher that has, elbow pain for 3 months, that has terrible shoulder mechanics, may or may not respond to an early course of physical therapy. But a pitcher who's been pitching who has pain for 3 or 4 months and then all of a sudden had severe pain or heard a pop in his elbow, to me, that would be more of the sign of, you know, something that would need to get an x-ray, because we'll see that a little bit more often. So to me, I think in the elbow or the upper extremity, I would really use the acuity as the key to really need to figure out if they need an x-ray or not, because I think a lot of these chronic problems can become acute. And we do see that, particularly with the medial epicondyle. Any other questions?
Dr. Ellis, thank you. Did you say you were going to send a link to some of these resources?
My understanding is that we will.
Okay.
But I'm not a computer. I'm not a computer guy, but we have a great team here that my understanding is everything that I presented today will have a link to it online, including the PDFs of the handouts, access to the videos, and then you know, I'll provide the access not only to the presentation, but as well as some videos of some special tests if we need to. Any other questions? Well, thanks, guys. I really appreciate your time, and we'll see you guys next month. Just for those of you who are planning on coming next month we're going to talk about the hip. Dr. Podeswa, who does a lot of our open hip surgery, he and I have a combined clinic about once every 2 weeks in which we just look at hip problems together. I'm an arthroscopic surgeon and a sports surgeon. He's a pediatric open hip surgeon, so we have a combined clinic. So he's going to talk to us a little bit about evaluating the hip and kind of staying out of trouble with the hip that may be really pertinent for open access PTs too, to kind of rule out things like skiffy and those, and how do you evaluate for a skiffy as opposed to initiating treatment on hip pain. So look forward to that next month, guys. Thanks again.